Allow me a moment. Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocator session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is advances in anesthetic pharmacology. Now, I would like to invite Dr. Muralidhar Kanchi sir to proceed. Over to you, sir. Thank you.
Thank you, Rimpa. It's a great pleasure and honor for me to invite you for this ICA webinar dated 3rd September 2025. As you are aware, the Indian College of Anesthesiologists, which is called ICA in short form, was an offshoot of Indian Society of Anesthesiologists, but it has independent existence from the year 2016, and it is managed independent of the ISA. And its focus is on academics and training, and its webinars, which are conducted on Wednesdays, has become a hallmark of the college and is most looked forward to by many trainee anesthesiologists as well as practicing anesthesiologists. It's my great pleasure that Dr. Jayashree Sood is also present with us, the president of ICA. And may I request Dr. Jayashree Sood to say a few introductory words welcoming the audience. Thank you so much.
Thank you so much, Dr. Kanchi. And now, welcome to all of you from the Indian College of Anesthesiologists. You've just heard from Dr. Kanchi, who is the dean of our college. And just to add on to what he has said that we have just concluded our 6th international and 16th national conference of the Indian College of Anesthesiologists in Jodhpur. We were there till Sunday, and it was a very successful conference, and which was really appreciated by all the delegates. So to let you all know that besides the webinars and these conferences, we also have fellowships, various fellowships which can be seen on our website. So please do go ahead, the delegates, see that, and you can apply for those fellowships and courses, as well as we have the yearbook of anesthesia, which was also released, the latest one, the yearbook of 2026, and that has also been there in the GCA, the journal. So a big welcome, and we have a very interesting college, the webinar today. So Dr. Kanchi, please start.
Thank you. Thank you, Dr. Jayashree, for joining us and your encouraging words. Thank you so much. It's my great pleasure to introduce you, Dr. G. Parameswara, Dr. H.S. Murthy, Dr. Kodandaram, as moderators and panelists for this evening's webinar. As you may be aware, Dr. G. Parameswara is a leading anesthesiologist of the city of Bangalore from the Manipal group of hospitals. And similarly, Dr. H.S. Murthy is the HOD and a prolific anesthesiologist, again from the Manipal Hospital, Bangalore. And Kodandaram is a pioneer anesthesiologist, professor of anesthesiology in Bangalore. With that, I would like to request Dr. Parameswara to initiate the proceedings of today, which will comprise basically of the anesthetic pharmacology, recent trends and advances. And I request Dr. Parameswara to take over. And you please request you to post all your questions and comments in the chat box. At the end of the 4 talks, we will be able to address them as far as the time permits. With that, I would like to request Dr. Parameswara to take over. Thank you so much.
Thank you, Dr. Murali, for this presentation. In the beginning, I would like to thank this ICA for giving us this opportunity to present these seminars on pharmacologic updates on our anesthetic drugs. So, most of our drugs which are there have been updated with various other either the this one introduction to newer features, or some of them have also undergone their different uses also, which was earlier was considered was not correct. So now we have about 4 topics to be done. Now, first topic is is on Remimazolam, which of course is a newer benzodiazepine drug, and it is making some waves because of the combination of the rapid recovery as well as other aspects of benzodiazepines which have been there. Now, for this one, Dr. Vinayak is a consultant anesthetist of our hospital, Manipal Hospital. He has many publications, national and international publications. He's also a reviewer for Indian Journal of Anesthesia, and he has authored 2 chapters on the Airway Manual book. He's also a member of National Academy of Medical Sciences, MNAMS. He has this. And he has worked in Bangalore Medical College, and he was now is in Manipal Hospital. He'll be talking about Remimazolam, a new drug profile. I now invite Dr. Vinayak to continue on his presentation. Vinayak.
Thank you, sir, for the introduction, sir. Am I audible, sir?
You are audible.
Okay. Good evening. At the outset, I'd like to thank the Indian College of Anesthesiologists, Dr. Muralidhar Kanchi, for inviting me for this webinar. And I'd like to thank Dr. Parameswara, Dr. H.S. Murthy for giving me this opportunity to present in this forum. Over the next few minutes, I will be talking on Remimazolam, which is a new drug which has been used for the past 6 years in anesthetic practice, and it's exciting use for us when it will be available for us in India. So this drug is an ultra short acting benzodiazepine that has been approved for clinical use since 2020. The patent was first availed in 2007, after which many clinical trials have taken place, and it was approved for clinical use from 2019 and 2020. And in 2021, the FDA approved its use in pediatrics for clinical trials also. Since it combines the properties of midazolam and the rapid metabolism of remifentanil, it has been named as Remimazolam. So what is different about this drug is it was developed using a new concept, that is a soft drug concept. That is, a soft drug is a drug wherein once the drug achieves its therapeutic effect, it is rapidly metabolized and excreted out into non-toxic products. This increases the safety and efficacy of the drugs by controlling their metabolism and minimizing their side effects. It has been developed by adding an ester moiety to midazolam. So this is different from the routine benzodiazepines, wherein it is independent of any organs for its metabolism. So it has a rapid onset, shorter duration of action, and very few side effects. If we see the chemical structure of benzodiazepines, the diazepam is the core of all benzodiazepines, and this is dependent on the liver for its metabolism. Midazolam was another innovation wherein an imidazoline ring was added to this so that it is water soluble at lower pH, and once it reaches the body pH, the ring closes and it becomes lipid soluble. Remimazolam, for this midazolam group, an ester moiety was added, and this makes it metabolized by tissue esterases, so that this is known as a soft drug design. So if you can see this ester moiety which has been added to this midazolam. There are 2 chemical formulations which are available for Remimazolam. Remimazolam bisylate, which is available worldwide, and Remimazolam tosylate, which is available in China. Both are functionally equivalent. So we all know that benzodiazepines act on the GABA receptors, especially on the GABA A receptors. It acts on the interface between the alpha and the gamma subunit. As we all know that the GABA encloses the chloride channel. Once the benzodiazepine acts on these receptors, there is increase in chloride influx, there is hyperpolarization and sedation. This is dose dependent. That means that at lower doses, it is anxiolytic, and higher doses, it has the sedative and hypnotic effects. Coming to the pharmacokinetics, the onset of action of Remimazolam is 1 to 2 minutes after IV administration. The peak effect is achieved by about 3 to 5 minutes after the first dose. The sedation duration is about 11 to 14 minutes, and it exhibits first order linear pharmacokinetics. And its plasma concentration is directly proportional to the administered dose, regardless of whether it is given as a bolus or a continuous infusion. Remimazolam is rapidly metabolized into an inactive metabolite, CNS 7054, and this does not have any effect, unlike midazolam, which are active metabolites. And if you see the increase in the plasma concentration of CNS 7054, that is its inactive metabolite, it starts increasing after the 10th minute and reaches its peak by about 15 to 20 minutes and is fully excreted out in the urine by about 100 minutes. So if you see the elimination, it is eliminated primarily by renal excretion of the inactive metabolite CNS 7054. The clearance, it has a very high clearance. It is about 70 liters per hour, and it is non-hepatic. That is why it is used. It can be used in patients with hepatic dysfunction also. There is no or very low tissue accumulation. The volume of distribution also is very high. It's about 0.76 to 0.98 liters per kg. It is rapidly distributed and has a steady state of distribution. Protein binding is very high. It is about 92%, and it is primarily bound to albumin. Its half-life is about 37 to 53 minutes. And when given as a continuous infusion, its context-sensitive half-life is very short, is about 7 to 10 minutes. What are the effects on various organ systems? On the central nervous system, it decreases the excitability of CNS depressant effect. It decreases the neuronal excitability. It causes dose-dependent slowing of the EEG activity, and at higher doses, it causes burst suppression. Because of this, it reduces the cerebral metabolic oxygen consumption. And also on the ICP, it is stable or decreases the ICP slightly. Therefore, it has good neuroprotective effect by reducing the CMRO2 and the excitability of the neurons. On the cardiovascular system, the heart rate, there is mild decrease or there's not much decrease. On the blood pressure, there's mild to moderate decrease in the blood pressure. On the systemic vascular resistance, there is slight reduction. That is why it has been found to be more stable than propofol on depending on the effect on the cardiovascular system. The cardiac output is well preserved, the baroreceptor response is preserved, and there is no myocardial depressant effects. Effect on the respiratory system, there is a dose-dependent, centrally mediated decrease in the respiratory rate. Tidal volume is usually preserved unless there is in higher doses or when combined with other narcotic drugs. Airway reflexes are blunted, but not as much as propofol. There is mild, centrally mediated bronchodilatory effect. And as with any sedatives, there is always a risk of apnea, hypoxia, and hypercapnia when used in higher doses or with other sedatives. Therefore, while using Remimazolam, you should closely monitor the respiration. On effect on other systems like GI, there is minimal effects. There is minimal nausea and vomiting. There is no effect on gastric emptying, and there is no hepatic effects. Changes in the hepatic functioning also. Musculoskeletal, there is mild relaxation of the muscle because of the centrally mediated action There is no myoclonus or rigidity. There is no direct action on the neuromuscular junction. Renal, there is no nephrotoxicity, and even in patients who have renal impairment, it can be used safely. How is it available? Remimazolam is available in the powder form. It is diluted using normal saline, and once diluted, it can be stored for 24 hours. And since it is an acidic salt, it is unlikely to promote any bacterial contamination, unlike propofol. But what we have to be careful is it has to be diluted only with normal saline. If you dilute it with either a sodium acetate or a lactate containing solution, it has been found to precipitate. And even while giving with a lactate containing solution like ringer lactate or a plasma light, you have to give it with a running solution. Otherwise, there is a high chance of it precipitating. Route of administration, it is approved for use intravenously, although there are some studies which have used it intranasally or rectally. It is found to be very irritating and causes severe pain to the patient. Thus, the current formulation is not advisable for any other route other than intravenous route. Dosage for procedural sedation, the initial dose is 2.5 to 5 milligram as an intravenous dose bolus for adults. Maintenance 1 to 2.5 milligrams every 2 to 3 minutes to achieve the desired sedation level. So we can, dosing is usually titrated to effect. For general anesthesia, the induction dose is 0.14 to 0.37 milligram per kg body weight or 6 to 12 milligram per kg per hour as a continuous infusion till the patient loses consciousness. And then the maintenance is 1 to 3 milligram per kg per hour, depending on the clinical response. What are the adverse effects? The common adverse effects are slight hypotension. There may be bradycardia. Usually the heart rate is not changed much. But what they've noticed is some body movement is noticed. This is not a myoclonic jerk. This is probably because the onset of action is slightly slower than other induction agent, and the peak effect takes about 3 to 5 minutes. That's why the patient may move. There may be some degree of nausea and or vomiting, but not as much as other drugs. Dizziness and headaches as with other sedative drugs. Respiratory depression when combined with other CNS depressants like narcotics. And it may cause anaphylaxis, especially in patients who are allergic to dextran 40. This is a part of the formulation. That is why any patients allergic to dextran 40, Remimazolam is contraindicated. The biggest advantage of using Remimazolam is that it has a time-tested antagonist, which is flumazenil, which can rapidly reverse its sedative effects. Flumazenil, as we all know, that it is a competitive antagonist of benzodiazepine at its binding site in the GABA receptor. So 0.5 milligram, a single dose can completely reverse the effect of Remimazolam, but there have been few case reports wherein when a large dose of Remimazolam is used or has been used as a continuous infusion for a long period of time, it may cause resedation. So because this antagonist is there have been studies that are using flumazenil to rapidly reverse the effects of Remimazolam. For example, this study, which was done in patients more than 75 years who are undergoing spinal surgery, they were using Remimazolam with flumazenil combination. They found that the extubation time was half that of propofol, 4 minutes versus 8 minutes. And also the time to eye opening, obeying commands, and for discharge score was significantly shorter. They found that they concluded that Remimazolam-based anesthesia with flumazenil resulted in faster emergence than propofol-based anesthesia in older patients undergoing spinal surgery. What are the clinical uses? The most common multiple studies which are available are for procedural sedation, endoscopies, colonoscopies, bronchoscopies, for sedation during central neuraxial block, peripheral nerve blocks, or for using during NORA that is outside operating room procedures like interventional radiology, MRI, and neurointerventional procedures. And it has also been used for general anesthesia for induction and for maintenance as a part of TIVA. There have been multiple studies over the past 6 years, and now multiple meta-analysis and systemic reviews are coming out. We'll go through a few literature for Remimazolam. This was a meta-analysis which came out in BJA in 2024, which compared propofol and Remimazolam for GI sedation, GI endoscopy sedation. They found that the induction time was slightly longer compared to propofol. And since it needed multiple doses of Remimazolam, they said that the sedation success was marginally lower. But what was important was the adverse effects like respiratory depression, hypotension requiring treatment, and bradycardia was significantly lower in Remimazolam compared to propofol. So they concluded that propofol is clinically similar and has greater safety when compared to propofol in GI endoscopies. Even for colonoscopies, when compared with midazolam, obviously the awakening time and discharge time was faster when compared to midazolam. Also, when compared with midazolam for bronchoscopies, they found that patient satisfaction was much more higher, and at the end of the procedure, patient was much more alert and could be discharged faster at the end of the procedure. And also the reversal, that is needing flumazenil, was much lesser in the Remimazolam group compared to midazolam, 3 times less in the Remimazolam group compared to the midazolam group. For sedation during regional anesthesia or during central neuraxial blockade, most often we use dexmedetomidine. But we all know once we start using dexmed, there is bradycardia, and post-operatively also there is sedation. This meta-analysis found that Remimazolam has similar efficacy as dexmed, with the advantages of lower bradycardia risk and faster sedation compared to dexmed. And a study in Canadian Journal of Anesthesia found the ideal dose for central neuraxial blockade to be around 0.6 milligram per kg per hour or 0.1 milligram per kg over 10 minutes. And they concluded that it has minimal respiratory depression and it may be the ideal drug for sedation during regional anesthesia procedures. Now, studies are coming out in children also. So this study was done in more than 120 children in the age group of 1 to 12 years. They found that younger children needed a higher dose for induction, that is 0.45 to 0.6 milligram per kg, compared to older children 6 to 12 years, wherein they needed about 0.35 to 0.45 milligram per kg. And they found no additional adverse effects in these in the study. In elderly patient, also this meta-analysis found that post-induction hypotension and intraoperative hypotension was significantly lower when compared with propofol TIVA compared to Remimazolam TIVA. Incidence of bradycardia was lower and patients had a slightly higher heart rate. The incidence of injection pain was lower, but the only disadvantage was longer time to loss of consciousness, and the BIS score was slightly higher in these patients. They concluded that Remimazolam has a lower risk of adverse effects in elderly and is well tolerated in elderly patients undergoing general anesthesia. This study found that the induction, they wanted to study what is the induction dose of Remimazolam in adults for general anesthesia, and they found that 0.14 to 0.33 milligram per kg is a good good induction dose for adult patients, and there was a loss of consciousness was achieved in about 1 minute after bolus induction, which is slower than that of propofol, and many of them had more than 1 minute to loss of consciousness after the induction dose. There were no serious adverse effects in this use of Remimazolam. In specialties also, in neurosurgical procedures, in hypertensives undergoing neurosurgical procedures, they found that there was using propofol tiva compared to remimazolam tiva, the incidence of hypotension was much higher in the propofol group, and there was no significant other adverse effects. And they concluded that hypotension incidence with remimazolam based tiva was comparable to propofol based tiva, and is equally suitable for patients undergoing neurosurgery, both propofol and remimazolam tiva. Post-operative delirium, there is no increase in post-operative delirium with the use of either propofol or remimazolam. It was similar. And the future is, since the pharmacokinetics is in between that of propofol and midazolam, you can definitely use it as a target control infusion. As of now, there is no commercially available target control infusion regimen available, although there are many studies which have put forward different regimens for remimazolam. Probably in the future, we'll have a regimen which will be available commercially. What are the limitations of remimazolam? The induction time is definitely slower than our conventional induction agents. For procedural sedation, you may need multiple doses to achieve sedation compared to propofol. Most of the studies are from China and Southeast Asia. There is limited long-term data. It is only about 6 years of data which is available. Clinical data. Before that, many studies have also been published. It is not FDA approved for pediatrics. Yes, definitely it is going to be more costlier than other drugs. Future research should include high-risk subjects, additional adverse effects, and non-Asian population and the Indian population for further enhancing our knowledge. I'd like to conclude by saying that remimazolam is a significant advancement in the field of anesthetic and pharmacology. It is ultra short acting, it has a rapid recovery, and has predictable pharmacokinetics and a favorable safety profile. Most importantly, it has a reliable antagonist, flumazenil, and it is an attractive option for procedural sedation, GA, and ICU sedation. So it will be a valuable addition to our armamentarium and maybe a promising alternative to propofol and midazolam. Thank you.
Thank you, Dr. Vinayak. And now
Thank you, sir.
I request Dr. Kodandaram to go ahead with the introduction of Dr. Suresh. Dr. Kodandaram, please.
Thank you, Dr. Parameswara.
So I'll
It
just
is
share
my-
my slides, sir.
Oh, it's my pleasure to introduce Dr. Suresh. He was my student during his post-graduation at ESI hospital, and I was his guide. He obtained gold medal for his MD exam. I have pleasure in inviting him to take up this lecture. He is going to talk on the anti-diabetic drugs like GLP1 agonists and also SGLT inhibitors. He is at present working in Manipal Hospital as a consultant, and he has got more than 13 publications and has delivered papers at various state and zonal national conferences. Dr. Suresh, please. Please take up your lecture.
Good evening, everyone. Thank you, Kodandaram sir, for your kind introduction. At outset, I would like to thank ICA, Muralidhar sir, Param sir, and Murthy sir for giving me this opportunity. So today my topic will be on update on anti-diabetic drugs. Mainly, I'm focusing on GLP1 agonist and SGLT2 inhibitors in anesthesia. So I don't have any conflict of interest or financial benefits. So as we know, when hyperglycemia is there, so there are various ways that body or the drugs we use will keep the glucose under control. Like one is on neurotransmitter dysfunction or impaired insulin secretions, increased glucagon secretions, or decreased glucose uptake. There are various drugs acting on a various mechanism to improve the to get their sugars under control. So in this, we'll be going to talk about two important newer drugs and its anesthetic implications. One is GLP1 agonist and the other one is SGLT2 inhibitors. Um, so first I'll be talking about GLP1 agonist. So for that, I need to know what is the uh, the effects of GLP1 and GIP1 receptors, which is happening in the body. So what happens when we take food? Uh, GIP, that is GIP is secreted by the duodenojejunal cells, and GLP1, the glucagon-like peptides, are secreted by hyalocolonic cells. These are nothing but incretins. So this acts on various parts of the body. For example, they initially acts on the pancreas. In the pancreas, they acts on the beta cells to increase the beta cell proliferations by in turn secreting the insulin. And they also acts on the alpha cells to decrease the glucagon release. So by itself, it can increase the beta cell apoptosis also. On the adipose tissues, it acts to increase the lipolysis, and it also decreases the ectopic fat reduction. By this, it reduces the fat in the body. Uh, in the stomach, it acts by decreasing the gastric secretions and also decreases the gastric emptying. In the intestine, it causes the decrease in the gastrointestinal motility. In the brain, it mainly acts on the satiety center to increase the satiety. So by these methods, on the one hand, it is increasing the insulin secretions and beta cell proliferation. On the other hand, it decreasing the lipid accumulation or fat deposition. Mainly, it is also causing the delay in the gastric emptying and increasing the satiety center. So it is also helpful for weight reduction. So more than the diabetic, it also is being used for other purposes. Like it also an additional to control the diabetes, it also decreases the weight of the patients. This is where it's mostly used. And along with increased glycemic control, it also improves the lipid profile. It also decreases the blood pressures. It also increases the inflammation by increasing the immune cells, and it also increases natriuresis. It increases the heart rate but decreases the infarct size and improves the LV function. So these improves the reducing the weight, improving the lipid profile in addition to glucose control. So what are those drugs? So these are the drugs which acts on the receptors, GLP1 agonist. So there are liraglutide. It's usually used for diabetes along with for the weight reduction. So it's usually used 0.6 mg subcutaneous once daily for a week. Maintenance, but 1.2 mg subcutaneous daily. Maximum dose we can go up to 1.8 mg subcutaneously. Semaglutide, it's available orally also, it's subcutaneously also. Subcutaneously 0.25 mg subcutaneous for 4 weeks, later 0.5 mg or 0.1 mg depending on the response. Maximum you can go up to 2 mg subcutaneous weekly. Whereas orally 3 mg orally, maintenance 7 mg or 14 mg, maximum you can go up to 14 mg. The other drugs are dulaglutide and teraglutide. Teraglutide is the one which has got GLP1 agonist also and GIP1 agonist also. This is the only drug which has got both the agonists, and that's why it's more helpful in weight reduction. So now why is the worry for us anesthetists? Because it has got some side effects, like starting from minimal nausea, dyspepsia, vomiting, diarrhea, and constipation to acute pancreatitis, neurological like headaches and dizziness, infections. So these side effects, if you slowly increase the dose over the months, these side effects can be reduced, or over a period of time, these side effects can come low. But for an anesthetist, what is important? We are worried about GLP-1 agonist and its gastric emptying. It significantly decreases the gastric emptying time. It reduces the gastric and duodenal peristalsis. So, but only good thing about that is it is subject to tachyphylaxis. So initially, if the patient is recently taking or recently increased the dose, the gastric emptying time is reduced. But over a period of time, tachyphylaxis happens. So over a period of time, this gastric emptying, although it do reduces. So these patients are prone for gastric delaying. So usually this ultrasound in this patient shows this is normal where the stomach is empty. But in some patients, when they are taking these patients, this shows there is liquid and is risk for aspiration. But most of the time, even the solid is also delayed. This shows there is solid early phase of your injection. So this is also risk for aspiration. This is a later phase of our gastric emptying. Even this is risky for aspiration. So to keeping this in mind, the ASA and Australian New Zealand guidelines have come to use these drugs in anesthesia. So if the patient on these drugs has got active GI symptoms, you have to delay the surgery, reduce the dosage or stop the drug, and then only take for surgery according to ASA guidelines. So, or if appropriately withheld their medications and do not have GI symptoms, you can proceed with the surgery. Asymptomatic, but he has not withheld the medications, we have to assume inadequate NPO status, but there is no GI symptoms. So better to perform gastric ultrasound. If contents are there, then no contents are there, you can proceed with the elective surgery. If contents are there, then better to delay the elective. What does Australian New Zealand guidelines tells? They tell active GI symptoms may not be a marker of retained gastric contents. So they recommend to stop the drug and use 24 hours to 48 hours only liquid diet before anesthesia. For non-endoscopic surgeries, uh, if these drugs are taken within 4 weeks, the better to stop and consider as inadequate NPO status. And for every case, if there is inadequate NPO status, they recommend using gastric ultrasound. They also recommend using prokinetic agents. But what we are going to do? So we are going to stratify these patients. So whether they're high risk or low risk. When do you tell it is high risk? It is GLP1 receptor. As I told, its recent history or high escalation dose. This GLP1 receptor history is there in the recent time. It is high risk. Comorbid conditions like gastroesophageal surgery, gastric reflux, morbid obesity, and medications like opioids, tricyclic antidepressant, proton pump inhibitors, or alcoholic use, these all are considered high risk. So on the day of surgery, what do you do? So whether we see whether he's adequately stopped the GLP-1 receptor agonist, yes, that means he's a low risk patient, we can proceed with surgery. No, that means he's an high risk patient for aspiration. Do gastric ultrasonography. If it is less than 1.5 ml per kg, you can proceed with surgery. Otherwise, you have to delay the elective surgery. If not, if it is an emergency, you should go with the rapid sequence induction. To summarize about this drug, so if it is a single dose, stop the single dose of daily taking medications like liraglutide. If it is a weekly dose, you have to stop weekly dose of semaglutide. Minimum 3 to 4 half-life has to be stopped. Otherwise, there is 4 to 10 fold increase in your gastric content. So this is about GLP-1 receptor agonist. Now going to the second part of the topic, it is SGLT2 inhibitors, that is sodium glucose co-transport receptors inhibitors. So where is this receptors present? This is present normally in the proximal convoluted tubule. So what is this function normally? It reabsorbs 90% of the glucose, sodium, amino acids, protein, and all the things. 90% of the timings it is reabsorbed. By inhibiting this, you are secreting the you are increasing the chances of glucose and sodium and other things not to be absorbed, and it should be thrown in the urine. That is how it controls the glucose. How does this story started? SGLT2 inhibitors usually started with type 2 diabetics. Now we are using in all forms of diabetics and non-diabetics also. Initially started as a diabetic drug, but now it is more utilized even in the cardiac failure patient. In the cardiac, um, it is used even in preclinical or subclinical stage, even in the clinical stage for heart failure prevention. There are various studies to the heart treatment. Even if there is already a failure, still these drugs can be used. Why is that so? Because this is acting in independent of the insulin productions or beta cell production, because whenever there is impaired beta cell, there is hyperglycemia that causes insulin resistance. This breaks this persistent hyperglycemia by excreting into the urine. So this breaks the channel. So it is acts by other mechanism also. As I told, it is more now used in cardiac patients. Why it is used in cardiac patients? Because it can reduce the preload, increase the free water clearance, decrease the pulmonary vascular pressures, decrease the glomerular pressures. It also acts effects on the myocardium. It increases the metabolic efficacy. It increases diastolic relaxation. It improves the oxygen demand supply better. So decreases the left ventricular hypertrophy, helpful in remodeling, decreases the fibrosis. Afterload, even the afterload is decreased, decrease in vascular stiffness, increase in autonomic balance and endothelial functions. By this, it causes improved cardiac structure and function. As I told you, it also decreases the intragranular pressures. This is more of a cardio-renal protective drug, especially beneficial in diabetic patients. Even it can be used in non-diabetic patients also. So what are those inhibitors? Mainly empagliflozin, DAPA, and canagliflozin. So it's usually used in diabetes, as I told you, heart failure, reserved heart failure, ejection fraction, or CKD patients. Cardiac protective, cardiorenal protective. Usually 10 mg orally once daily. Maximum can go up to 25 mg. Dapagliflozin, same indications, used as 10 mg orally. Maximum is 10 mg only. So it's a fixed dose. So telling so, what is the problems for us? The problem, one of the main problem is because it's excreting the glucose and sodium. So the main problem for us is dehydrations. When these patients are taken for a long duration of time, dehydration happens. So it causes anorexia, nausea, vomiting, dyspnea, and such things. What did this causes is it causes something called euglycemic diabetic ketoacidosis or euglycemic ketoacidosis. In simple terms, the glucose, even though it is well controlled, that's why the diagnostic criteria is glucose should be less than 200. Even though the glucose is well controlled, there is again ketone bodies. We'll see why it happens. So what happens in SGLT2 inhibitors, as I told you, it increases the glucose secretion in the urine. So it reduces the serum glucose level. If this patient is coming for surgery, is fasting, again the serum glucose levels are level. So the glucose is under control, that is euglycemia. This causes decrease in insulin. This increases the counter-regulatory hormones. This SGLT2 also stimulates the glucagon, so the increased lipolysis, increased keto acids, and this is what causes anionic gap metabolic acidosis. And the glucose is under normal, so it causes euglycemic ketoacidosis. So what we should do? Pre-operatively, when this patient comes, you should discontinue at least 3 to 4 days prior to surgery because half-life is around 16 to 24 hours. It's better to discontinue 3 to 4 days prior to surgery. These are the patients who are coming for cardiac. The cardiac patients or renal patients. Kindly look into this newer diabetic, anti-diabetic drugs. Discontinue for 3 to 4 days. Monitor blood glucose. You are discontinuing the drug, so you have to monitor. If required, the patient is admitted. You treat hyperglycemia by insulin. So advise continued clear liquid intake up to 2 hours because here the dehydration is more important rather than anything else. So intraoperatively, what to do? Monitor intravascular volume. Don't allow for dehydration because the patient is already fasting and diuresis is happening continuously. Monitor the acid-base status if you think your surgery is requiring a lot of fluid shifts and massive fluid losses. Monitor and treat hyperglycemia with insulin. Avoid other glucocorticoids because it can increase the counter-regulatory hormones. Post-operatively, continue pre-operative insulin dose with dextrose if there is ketoacidosis. Monitor acid-base status. Daily monitoring. If the patient is already having euglycemic diabetic ketoacidosis, you see for daily monitoring of serum ketone bodies. You should not prematurely decrease the insulin. So if you reduce the insulin, there can be chances. Exclude other causes for anion gap metabolic acidosis, renal failure, and lactic acidosis. If you think the patient is in ketoacidosis, it's better to shift to ICU and reinitiate only when the adequate hydration and nutrition has been re-established. So pre, intra, and post-op. Is there a modality to reduce the? Yes, we can prevent it also. How do you prevent it? So prevent the euglycemic diabetic ketoacidosis, cessation of SGLT2, as I told, 3 to 4 days before elective surgery. So because T of life is varying from 1 to 16 hours, it's better at least 24 hours. to be given better 3 through 4 days. If given as treatment for diabetes, initiate subcutaneous insulin because preoperatively the patient can be under stress and the glucose can increase. Other risk which can happen, we should be worried is it can cause natriuresis or osmotic diuresis. As I told, it is a hypotension and orthostasis because of intravascular volume is decreased. And as glucose urea and glucose is secreted in the urine, there are chances of genital yeast infections. So to summarize, what is we are thinking about GLP-1 agonist and SGLT2 inhibitors. So GLP-1 GI effects are very common because gastric emptying is decreased. So you should be more worried about gastric emptying time. Here it is very rare. Whereas euglycemic diabetic ketosis is low in GLP-1, it's moderate to high risk is there in SGLT2 inhibitors. So what do you do about preoperative withholding? The GLP-1 agonist at least 24 to 48 hours, or if they are taking for one weekly, 1 week, one dose has to be skipped. Here, minimum 3 to 4 it has to be skipped, but always monitor the blood glucose level. Dehydration risk is mild to moderate in GLP-1 agonist, whereas it is very high in GLT2 receptors. So GLP-1 worry about the gastric emptying time. GLT2 inhibitors, we have to worry about the dehydration risk. So these are my references, and thank you.
Thank you, Dr. Suresh. It was an excellent update on both these drugs. And I hand over Dr. Parameswara for conducting the next part of the program.
Thank you, sir. Thank you very much.
Thank you, Dr. Kodandaram. Now we'll move on to our next topic, that is an update on new roles of ketamine. As you know, ketamine has recently been used for many other uses other than just anesthesia, and we'll know more about this. And Dr. Anita is going to talk about this, about newer roles of ketamine, and she is also our consultant in an anesthesia at our Manipal Hospital, and she's on the editorial board of Journal of Anesthesia Critical Care. She has been an examiner. She has done with assessment faculty, and she has been invited in the World Federation Society and has special interest particularly in neuroanesthesia, pediatric anesthesia, and regional anesthesia, where ketamine is also is one of the used drugs which have. So we'll know about more updates on this ketamine for the newer roles. Dr. Anita, please.
Yeah, thank you, sir, for that kind introduction. Good evening to everybody. At the offset, I would like to thank the esteemed senior ICA members and Param sir and Murthy sir and for giving me this opportunity to speak on this forum today. I'll be speaking today on recent advances in ketamine use in anesthesia and the ICU. There is no potential conflict of interest. This first slide that I have shared actually shows some, trivia about the history of ketamine. Ketamine actually has a very dark precursor, phencyclidine or angel dust, which was the first non-natural man-made illicit drug of abuse. And it was coined as one of the most dangerous drugs in the US in the late 70s. Ketamine was actually synthesized in 1962 by Dr. Stevens, but the first clinical study of ketamine was published by Domino et al. And it was his wife who coined the term dissociative anesthesia for its unusual state that it produces. Around 1970s, FDA approved it for use in war because of its unique properties, being easily transportable, no refrigeration required and all. By 80s to 90s, recreational use of ketamine came into fore, and 2000 and beyond, its use in chronic and acute pain treatment, antidepressant effects, and psychiatry came ahead. Till today and even ongoing, there is a lot of research happening in the field of different uses of ketamine. We all know that ketamine is an NMDA receptor antagonist, and it exists as a racemic mixture of equal amounts of R and S ketamine. Now, these are non-superimposable stereoisomers basically. An example of familiar objects is like your right and left hand. Now, what is unique about S-ketamine, which is now available in the market for use, is that it has got a higher affinity for the NMDA receptor, having a faster onset, elimination, metabolism being faster. It is more potent with fewer psychomotor effects, dissociative effects, long duration of action, and there is a shorter duration of its antidepressant effects. So it is available as a nasal spray as well as a IV formulation. We all know that the ketamine's mechanism of action is via agonism and via antagonism at multiple receptor levels. This is just a slide which just shows the areas where all ketamine can act. So, with such diverse molecular targets and neurophysiological properties, its effect on the CNS is yet incompletely understood. With a wide therapeutic range, ketamine is also one of the safest anesthetics which is available when used with known dosing regimens. There are various routes of administration of ketamine, especially because of the fact that it is highly soluble in both water as well as lipids. In emergency settings, intraosseous use is very highly recommended, or by use by people who are less familiar with the other modes of administration of ketamine. Oral and sublingual formulations are now available in low-dose ketamine formulations, especially for treatment of pain, chronic pain, and in cancer pain, or for depression in OPD settings. The sub-anesthetic doses of ketamine or low-dose ketamine is what is described as less than 0.8, starting from zero point 0.2 milligram per kilogram IV or less than 4 milligram per kilogram IM. And also infusions of 0.5 milligram per kilogram per hour these are the doses of ketamine which is being explored in various forums nowadays. So we all know about the pharmacodynamics of ketamine being such an old drug which we have been using since so many years. The only I have just stressed on certain aspects of ketamine which are now come to more use. Like though we knew always that CNS effects of ketamine includes increasing the metabolic rate, CMRO2 and the ICP. Now there are neuroprotective effects of ketamine which have come to fore. So based on this, ketamine is now being used even in for sedation in the neuro ICU and for traumatic brain injuries and all, because it inhibits the spread of cortical depolarizations, which can result in secondary brain injuries. Now, we know about its sympathomimetic effects on the heart. We also know that it helps to preserve upper airway reflexes. An interesting fact is that it also increases the genioglossus muscle activity, because of which the airway collapse is prevented. And this is the basis of its widespread use in the emergency department or in the war situations and all, wherein it can be used by people who are less frequently using anesthetic agents. This slide just shows a summary of clinical uses for ketamine in present day scenario. I'll just go into some details of use of ketamine. We all know that ketamine can be used in situations where there is hemodynamic instability. So while giving general anesthesia, it is known, the other drug which is used in this circumstance is etomidate, but etomidate is also known to cause adrenal suppression. Ketamine, on the other hand, causes lesser adrenal suppression when compared to etomidate. It is being increasingly used in military and civilian trauma anesthesia in the emergency department, also in the OT, wherein patients can be, wherein the patients are hypotensive and having a lot of hemodynamic instability. Other use of ketamine in general anesthesia is when we are administering obstetric anesthesia. It is one of the few drugs which is approved for IV induction in cesarean sections, without significant neonatal respiratory depression. And this maintains normal neonatal oxygenation at appropriate doses, not higher doses, 1 to 1.5 milligram per kilogram. When we use ketamine for sedation, IV doses of around 0.2 to 0.8 milligram per kilogram, that is a sub-anesthetic doses of low dose ketamine, helps to achieve whatever is the desired sedation within 1 minute, and this can last up to 5 to 10 minutes. Because of use of low dose ketamine, unwanted psychomotor side effects also can be are less seen. If they occur, small doses of propofol or benzodiazepines can be given. Now, I'll just highlight certain studies which have been done, wherein ketamine has been used for, in pediatric emergency medicine. It has been used extensively, wherein burn therapy is required, or other treatment procedures in the emergency department, like abscess drainages, joint dislocation reductions, fracture manipulations, foreign body removal, etc. Now, this is a study which was published very recently, which involved, it's a meta-analysis which involved 16 studies involving more than 3,000 pediatric patients, wherein the stress was laid on ketamine monotherapy, mostly low-dose ketamine monotherapy. This meta-analysis revealed that there is rapid recovery and acceptable safety in low-risk scenarios in low-risk patients as well. And if ketamine is is given along with say a benzodiazepine or a propofol, is when there could be some airway complication or some hemodynamic instability which was noted. Basically, this meta-analysis rooted for ketamine monotherapy in this situation. There's another study which tried to lay more importance on the protocolized administration of oral ketamine in pediatric patients. Basically, there is a lot of, though the drug is given extensively to various sections of the pediatric patients, there is lack of comprehensive evidence because of lesser RCTs which are done, which have not given us the exact dosing which can be given to children when oral ketamine is administered, especially when we are dealing with critically ill or other diverse children. So there are certain institutions and certain countries which have come out with guidelines, and one of the safer guidelines which is being prescribed is using 1 to 1.5 milligram per kilogram of initial ketamine dose, followed by incremental doses of half the doses, basically every 10 minutes, up to a maximum of 4.5 milligram per kilogram. Its use in pediatric ICUs is also a place where a lot of study is happening. Basically, it's advantageous in these conditions because of its hemodynamic and stability, and also in children, wherein bronchoconstriction is one worry which can happen. So bronchodilator effects of ketamine, and possible also modulation of the inflammation cascade in seriously ill children in the ICU. Ketamine can be of beneficial effect in these children. However, the neurobehavioral consequences because of ketamine use in these children is still quite uncertain. Now coming to going beyond pediatric use, either anesthesia or ICU, spinal or regional. We all have used ketamine as adjuvants in spinal or regional anesthesia. There is marked analgesic effect even when studies have shown that even when administered alone, ketamine gives good effects in spinals. And if there is a hemodynamically unstable patient in whom we have to give regional anesthesia, combining ketamine with local anesthetics decreases the amount of local anesthetics which is required, and also gives prolonged duration of analgesic action. in these patients. So this is one study, recent study, which has emphasized this result. This involved more than 1,000 patients and more than around 20 RCTs. Ketamine's use in pre-hospital, military, and disaster medicine is well studied and well known. Basically, because of its wide safety margin and multiple routes of administration, ease of administration, and transport. Also, in resource limited environments, the use of ketamine has been well studied. These are the multiple recent events beyond 2000 wherein ketamine has been used, and these case series have been published as well regarding this. A 2020 survey, something to note is a 2020 survey of helicopter rescue services in Switzerland. All of them reported ketamine to be safe and useful, and even described it as irreplaceable. Now, coming to ketamine and its use in acute pain, we all know that we are all going towards a world of using lesser opioids in this, especially in the developed countries wherein opioid dependability is a major concern. So they are all looking at non-opioid methods of analgesics, wherein the sub-anesthetic or low-dose ketamine, which I explained earlier, has been proposed to have analgesic effects which are similar to morphine or fentanyl without the profound respiratory depression which is usually associated with opioids. So much so that in 2017, the ACEP, that is the Emergency Physicians Association in America, they have recommended low-dose ketamine as an analgesic treatment which can be used alone or as a part of multimodal approach in acute pain treatment in the emergency department. Now, this Cochrane review on perioperative use of ketamine for acute postoperative pain in adults demonstrated the utility of this drug in reducing pain, reducing opioid consumption, and PONV across a wide range of surgeries and patient groups. So all this has, because of all these results of meta-analysis which has come out, NICE guidelines, the UK-based NICE guidelines in 2020 have suggested that moderate to severe pain in the perioperative period can very well be treated with low-dose ketamine or sub-anesthetic doses of ketamine. So this is a table which shows the doses for when we are using low dose ketamine as for either acute or chronic pain. In chronic pain, ketamine's use comes because of the variety of places wherein ketamine or mechanism of action of ketamine at different sites. Because of NMDA blockade, decreased receptor affinity for substance P, and modulation of astrocytic or glial responses, or blocking the muscarinic receptors. All these sites of action are where ketamine can be of help in chronic pain. Beyond pain, now I'll just speak about its use in the neuro ICU. Previously, as I mentioned before, and as we all know, the use of ketamine in neurosurgery and neuro ICU was not recommended because of proposed increase in ICP because of this drug. However, now it has been discovered that ketamine has neuroprotective characteristics. It has beneficial cardiocirculatory properties. It also reduces vasopressor consumptions in patients in the neuro ICU. And that is why now there's this retrospective observational study which was published in 2016, which proposed that, which came to the conclusion that ketamine actually decreased ICP in more than 90% of the cases, and more than 50% of the patients' vasopressor requirement was reduced. And also that it came out with the thing that the result that the rate of major complications was not high at all when compared to the non-ketamine group. There are various newer potential and perspectives regarding ketamine in neurocritical care because of its unique pharmacological profile, as mentioned earlier. And one reason why ketamine is valuable in managing patients with neurological injuries is because it helps to maintain the cerebral perfusion pressures. This can also, and because it can also be extended to a wide range of population, including the pediatric population. This slide just describes the neuroprotective mechanisms of ketamine, which includes reduction in inflammation and antimicrothrombotic properties, and reducing the cerebral ischemic zones, and in spreading depolarization and thus the frequency of seizures in these patients. So in traumatic brain injury, the property of ketamine in inhibition of spreading depolarizations also these are the depolarizations are one which are contributing to secondary brain injury in these patients. So by inhibiting these spreading depolarization waves, ketamine exerts lot of neuroprotective effects. This, along with minimization of the systemic inflammatory response, and also by its other effects of cardiovascular and respiratory stability, it has become a particularly appealing agent for sedating TBI patients in the neuro ICU. Now, coming to other managements in the ICU, in patients who have severe agitation and anxiety, and psychiatric patients basically, ketamine has, in a low dose, that is 0.35 milligram per kilogram infusion, has helped to assist in weaning from ventilator and for extubation in those, especially who have had multiple failed spontaneous breathing trial attempts. Its use in asthma, because of the physiology of ketamine, again exerting its effects via various kind of receptors, it increases basically the pulmonary compliance and causes bronchodilation. This is a well-known fact about ketamine. However, still, a study by Lavia and colleagues in 2022 concluded that there is very limited number of studies available, and that is why it cannot be proposed as a treatment modality in severe asthma. It cannot be recommended basically as a treatment modality in severe asthma, though we all know that it is a potent bronchodilator. In the 2000s, ketamine's importance in psychiatry department has come to fore, basically for the treatment of major depressive disorders which are treatment resistant, for post-traumatic stress disorders, for substance abuse patients. And in a recent study in 2024 by Wang and colleagues, postnatal depression, treatment of postnatal depression using ketamine has been documented. S-ketamine, with its immediate and significant result, has also helped in reversing suicidal ideation with immediate effect. The intranasal variation spray of S-ketamine is basically used for this condition. In the treatment of status epilepticus and other CNS disorders, also ketamine and its other variations such as memantine is being investigated in conditions including Alzheimer's, Parkinson's, and Huntington's, especially because of its NMDA blocking property. There are other studies which have shown how low-dose ketamine can be also used in maintaining hemodynamic stability when a patient or undergoing spinal anesthesia experiences hemodynamic instability, which we come across quite often. Low-dose ketamine can be used in this condition, which also provides good sedative and analgesic properties, along with providing cardiovascular stability. The other use of S-ketamine, wherever it is available, or ketamine, has also been found in conditions wherein we use surgeries, wherein we use intraoperative neuromonitoring, along with drugs such as propofol or fentanyl, remifentanil, or dexmed, which are used commonly. So adding ketamine or S-ketamine in these patients in low doses, like which will not alter the monitoring in these patients, has shown that the doses of propofol, fentanyl, and dexmedetomidine can be significantly reduced when we add on a low dose of ketamine as well in these patients. However, there is more research which is required in this condition. The latest application of ketamine it stresses on its anti-inflammatory and immune modulation. There have been various studies, meta-analysis, which have shown that in surgeries such as CPBs, abdominal thoracic surgeries, and cataract surgeries, there is significantly reduced inflammatory markers which have been noted in the post-operative period. A recent review by Johnson and colleagues also highlights the links between chronic depression and chronic inflammation. So by reducing the chronic inflammatory markers, ketamine has been used for treatment of depression. More research is happening in this area as well. Now, this is an interesting fact which has come about ketamine, about its use in onco anesthesia and generally in onco anesthesia. Basically, the ketamine has been used for managing cancer-related pain. Recently, low-dose ketamine has been used. Oral ketamine has been used in managing cancer-related pain. However, there are recent studies which are done in 2018, 19, and including 2024, which have found that ketamine upregulated a leukocyte or a NKC activation marker CD69, which is downregulated in lung CAs. So this results in an increase in apoptosis of the malignant cells in this condition. Another study in 2019 has described that ketamine attenuates the malignant potential of cancer cells and prevents cell migration using NMDA antagonism. However, in a 2024 meta-analysis, Rodriguez and colleagues reviewed this evidence for using perioperative ketamine, especially in looking at cancer recurrence. Though the results appear highly promising, there is still lack of sufficient evidence to propose its widespread use in cancer patients for the sake of prevention of recurrence. There is need to standardize research methodologies to bring out some positive response in this aspect. So those were all my regarding the recent advances in ketamine use. Apart from whatever we have been using, whatever conditions and situations we have been using ketamine so far in our practice. So these are my references. So we have used ketamine in multiple forms, in multiple situations over more than 50 years in the past, and many patients have benefited from this drug. And we are anticipating that many more discoveries will be done in the next coming years, so that especially when it comes to modulating the mind. Thank you.
Thank you, Dr. Anita. It was a wonderful talk. Now we'll move on to the next topic, the last topic, that is on remifentanil. Even though this drug has been there for quite some time, it has been recently available in India, and it's being used nowadays. And I request Dr. Vaishali to kindly present her updates on remifentanil. Dr. Vaishali is our consultant anesthesia at Manipal Hospital. He has been one of the quite a good presentations and research aspects of various, particularly regarding the obstetric anesthesia and other anesthesia as well. Dr. Vaishali, please.
Great. Am I audible, sir?
Yes, you can go ahead.
Okay. Greetings from the Manipal Hospital, Bangalore. Good evening. I thank organizers of Indian College of Anesthesiologists and Dr. Murthy sir and Param sir for giving me opportunity to talk on this topic. So we all know change is the only thing constant in our life. As an anesthesiologist, we should adopt a new change, new drugs, and new monitors or techniques for the betterment of our patients' care. So here comes today's topic of discussion. So updates on the Remifentanil. It is a relatively new drug. Before going to the actual topic, I disclose that I don't have any conflict of interest. So this is format of my presentation today's presentation. Okay. So Remifentanil, it is a relatively new drug, came from couple of years in India, although it has been FDA approved in United States, and it has been in regular clinical use from last 2.5 decades. So we are actually new to these drugs. So Remifentanil will go to a structure of the Remifentanil. It is an ultra short acting synthetic selective receptor agonist with a selective mu receptor agonist with a fast onset and fast offset of the action. It has a 4-anilido piperidine chain, structurally similar to like fentanyl, alfentanil, and sufentanil, but then it has an added ester group, which gives a unique pharmacokinetic for these drugs. This drug comes as a soft drug. That means it has a predictable and controllable metabolism to the non-toxic moieties after it achieves their therapeutic role. So how does this remifentanil is metabolized? It is metabolized by the non-specific esterases in the blood and tissues, and not by the plasma cholinesterase. So can be safely used in the pseudocholinesterase deficiency patients. And its a metabolite is remifentanil acid, which is a very inactive, and this metabolite is almost 300 to 4,600 fold less active than the primary drug. So how does remifentanil is clear? The clearance is very fast, almost 4 liters per minute. Whereas if you compare with the fentanyl, it's only 1.5 liters per minute. Here comes the context sensitivity half-life of the remifentanil. So we can see the graph. On the y-axis, we have a context sensitivity half-life of the drug, and on the x-axis, we have a duration of the infusion. On the bottom line, there is a one dotted yellow line, that is the remifentanil. Here we can see even after the prolonged infusion for almost 10 hours, within 5 to 10 minutes, we can get the drug out of the body. That means the blood concentration decreases to the 50% within 3 to 6 minutes, and a recovery from the effect occurs rapidly within 5 to 10 minutes. So no accumulation even after the prolonged duration of the infusion. So it's a very good drug for the long duration surgeries. So after seeing the pharmacokinetics, we can come to conclusion like it's a rapid onset of action, that is 30 to 60 seconds, rapid and predictable elimination by the non-specific plasma and tissue esterases. Because of that, it will have a rapid recovery and awakening. So it is very good drug for the fast tracking of the procedures. So short comparison between our most commonly used drug fentanyl and remifentanil. Onset of action, if you compare, remifentanil is only 30 seconds, and whereas fentanyl, it is 1 to 2 minutes. After injection, the maximum concentration is achieved within 1 minute for the remifentanil, whereas for fentanyl, it is 3 to 4 minutes. And the half-life of the drug, it is only 9 minutes for the remifentanil, whereas fentanyl is almost 3 to 4 hours. Context sensitivity half-life of the fentanyl is more than 100 minutes, whereas it's for the Remi, it is only 3 minutes. And the most important thing is the drug is metabolized by the non-specific esterases in the blood and the tissue. So it can be safely used in the patients with a hepatic and the liver impairment. So what is the dosage of the remifentanil? For the neonates and children, it is the 1 microgram per kg as an induction dose. Induction, it's not a bolus. It has to be given over a period of 30 to 60 seconds. And maintenance infusion should be given as a 0.3 to 0.4 microgram per kg per minute. It can be given in the range of 0.05 to 1.3 microgram per kg per minute. Whereas in adults from 12 to 65 years of age, we can use it in a dose of 0.5 to 1 microgram per kg. And for infusion, we can use as a 0.25 to 0.25 microgram per kg, and the dose can range from 0.05 to 2 microgram per kg per minute. In older individuals, older than the 65 years of age, we need to reduce the dose by 50%. Whereas for infusion, we have to reduce the dose by 25%. And we can use this drug even in the severely obese patient. We have we need to calculate the dose according to their ideal body weight. So what are the strengths available for this remifentanil? It is 1 milligram, 5 milligram and 2 milligram. But in India, we have only 1 milligram and 2 milligram vials. So how do we prepare the drug? We need to prepare the drug with the addition of the saline or the distilled water. So there is a standard concentration. We need to make the drug in a 50 microgram per ml only. So for 1 milligram ampoule, we can add 20 ml of saline. And for 2 milligram ampoule, we need to add a 40 ml of the saline. So we'll get the concentration of the 50 microgram per ml. So how do we use this drug in our clinical practice? We can use with a TCA pump or we can use it with a TIVA pump also. So TCA, there are two models available, Minto model and Elevate model. What is the difference between these two models? Minto model is available for 12 to 90 years of age, and Elevate is available from 1 to 99 years of age. So, but at present in India, we have only Minto model available. So we'll just in short, we'll see how we are going to set the pump and how we are going to use the drug. So when you open on the TCA pump, we need to select TCA Remi first. The second thing comes as a concentration. We need to select as a 50 microgram per ml. Then mode, we need to use the effect mode. What is effect mode? It is a concentration of the drug in brain. Then we need to add the demographic data like age, sex, height, and weight. We have to have a dedicated IV line with an anti-reflux valve to use the remifentanil. Once we have set with all these things, we can connect the ICA standard monitors to our patient. Then we need to complete the WHO surgical safety checklist. Meanwhile, we can start pre-oxygenating the patient. Then we need to start the TCA pump. Initially, when we are pre-oxygenating, we can keep as a 1 to 2 nanogram per ml. These doses are according to the recommendation of our EVOTA India. This is Association of the TIVA TCA as an anesthesiologist group. So to start with, we can start with 1 to 2 nanogram per ml when we are pre-oxygenating the patient. Once we have done that, we can induce the patient with 4 to 5 nanogram per ml. If we are combining with the Propofol, we can start the Propofol TCA at 4 microgram per ml. The dose titration is required as per your patient's need and the surgery. After that, we can secure the airway and we will have and we can also use the relaxant if it is necessary. Maintenance can be done with a 4 to 6 nanogram per ml. Depending upon the stage of the surgery, dose titration can be done. If there is any intense stimulus expected during the surgery, we can give a bolus of the remifentanil also. It is recommended that nociceptive monitoring and entropy monitoring is required for the using the remifentanil infusion. So how do we terminate the TCA pump? So once the surgery is getting over, we can slowly taper the dose to 3 nanogram per ml. Around 15 minutes before the completion of the surgery, we need to ask the surgical team to infiltrate the surgical site with a local infiltration. And we can also, if it is possible, we can also give the peripheral nerve blocks. Other choices are opioid like fentanyl boluses also can be given, or long-acting opioid boluses like morphine also can be given. And other multimodal analgesia also can be used. Then we can reduce the TCM dose to around 0.5 to 1 nanogram per ml till the dressing is complete. Then we can stop and we can see the patient will be awake and obeying the command within 5 minutes after the stoppage of the infusion. So if we don't have a TCA pump, can we use the remifentanil? Yes, we can use. We just need to calculate the dosage of the infusion. So if we have the weight of the patient, we can multiply with the 0.12. We will get the ml per hour. Suppose we have a 70 kg patient, we can multiply with the 0.12, we'll get a 8.4 ml per hour. So this is the strength approximately equivalent to the 0.1 microgram per kg per minute. So during the surgical stage, if we want to increase the dosage, we can increase to the 0.2 microgram per kg per minute also. In that case, we just need to double the infusion rate, that is 16.8 ml per hour. So we also have some apps on our mobile. We can download those apps like Tiva Trainer app, Tiva Trainer app, or iTiva Anesthesia app. So these apps we can just enter the demographics of the patient, and we will get the infusion rate, and that same infusion rate can be put in our regular infusion pumps. So this is a Remifentanil Tiva and TCI comparison. We can see here approximately around 0.2 microgram per kg per minute is equivalent to 3 nanogram per ml. So we have seen now pharmacokinetics of the drug. Now what is the pharmacodynamics? What drug does to the body? So here comes the effect. The cardiovascular system, it causes a dose-dependent decrease in the heart rate and blood pressure. Minimal effect on the myocardial contractility, reduced myocardial oxygen demand. It is, if we titrate the dose properly, it gives an excellent hemodynamic stability. On respiratory system, it causes a dose-dependent decrease in the respiration. Chest tightness or a wooden chest is also observed as one of the common side effect of this drug. And if it is more common if the higher dosage is used, or if we have not combined any hypnotic agents like propofol. In central nervous system, with 1 microgram per kg infusion, there is no effect on intracranial pressure and minimal decrease in the mean arterial pressure and cerebral perfusion pressure. There is no change in the cerebrovascular reactivity to CO2 or no epileptiform activity on the EEG. So very safe for even neurosurgical procedures. As I have told before, there is no effect of the drug on the renal and hepatic function. So it can be safely used in the renal and hepatic impairment patients. Even there is no change of the intraocular pressure, so safe for the ophthalmic procedures. It is excellent in attenuation of the sympathetic response to the noxious stimuli like intubation or intense surgical stimulus. It can be used in a pseudocholinesterase deficiency patients. So what are the undesirable side effects? The most common side effect, these are bradycardia, apnea, and hypotension. Skeletal muscle rigidity also comes as a most common side effect. So it's more common if we give a higher dosage or if it is not accompanied by the hypnotic agents. The best way is to first give the hypnotic agent, then start the remifentanil. So the chances of skeletal muscle rigidity is less. If at all it happens, it is a very short-lived and we can treat it with a muscle relaxant. The other side effects are acute respiratory depression and depression, that is apnea. So whenever we are using Remi, we should be ready to take care of the airway. The hypotension is another common side effects wherein we need to keep the vasopressors ready. So elderly patients who are undergoing the major surgeries, we can keep the vasopressor connected when we are using the remifentanil. The postoperative hypertension is one of the side effects which is a very common and it is a little worrisome in a neurosurgical patients. So other postoperative shivering, nausea, vomiting, these are other side effects of the remifentanil. So where this drug is contraindicated, this drug is contraindicated for the epidural and the intrathecal use. As we know, there is a preservative glycine, which is a neurotoxic. So it is not recommended for this epidural or the intrathecal use. Others contraindications are hypersensitivity to the drug or hemodynamic instability. Patient with a very poor cardiac reserve, we should avoid this drug. And it is not recommended as a sole anesthetic agent. So what are the recent updates where we can use this drug? We know that this is utilized for the regular anesthesia purpose. So enhanced recovery after surgery. It is a core component of the ERAS protocol, which provides the intense intraoperative pain control without hangover effect, early patient mobilization and discharge, and opioid minimizing anesthesia. So it is very preferred drug for the ERAS protocol. For awake intubation, it's a profound suppression of the airway, allows for the awake fibrotic intubation, and also patient with a difficult airway where we cannot use the neuromuscular blocking agents. So it's an excellent drug in those cases. Surgeries where the muscle relaxant is avoided, like thyroidectomy, parotidectomy, scoliosis surgery, spine surgeries, neurosurgeries where the neuromuscular monitoring is used. This is an excellent drug where we can avoid the muscle relaxant. It is also used recently in interventional radiology procedures where the patients are for the daycare procedures. They will be discharged on the same day. It's a very useful. For the ICU sedation analgesia, for a short-term sedation in management of the critically ill mechanically ventilated patient, it's a good drug, especially those patients with a hepatic impairment, hepatic and the renal impairment. So it is also been introduced in the obstetric anesthesia as IV-PCA, where we cannot use the neuroaxial anesthesia or a labor analgesia epidural, or where the patients are having the coagulopathy, or it is contraindicated for other reasons. So pediatric anesthesia also it is used because of its rapid and the predictable effect. So these are some studies where they have used the remifentanil for a tracheal intubation without neuromuscular blocking a drug in adult patients. And they found that remifentanil may be used as an alternative drug for the tracheal intubation in cases where the neuromuscular blocking drugs are best avoided. And it gives the equally good condition like neuromuscular blocking drugs. So it is, this is another study which is done in China, which explains the protective effect of the remifentanil on preventing the organ ischemia reperfusion injury. And it is advised this drug can be considered to elevate the organ ischemia reperfusion injury. So non-regional analgesia for labor, as I explained before, the patients where the labor epidural is contraindicated, this is advised. We can use the remifentanil. Here, the dose advice is they have used as a 40 microgram as an initial dose, followed by the 20 microgram every 2 to 3 minutes as a bolus injection. 2 to 3 minutes of lockout period. This is another study where they have compared remifentanil with a dexmedetomidine for a sedation during the modified awake fiber optic intubation. Here, they achieved they found that statistically no significant difference between the remifentanil and dexmedetomidine for this intubation. But then, because of its excellent pharmacokinetics, remifentanil achieved a better intubating condition within a shorter span, and there was a very less coughing. So what is the modern anesthesia cocktail? The remifentanil propofol-tiva, a synergistic combination that is now the gold standard for the intravenous anesthesia. Here, the drug potentiates each other's effect, so allowing the lower dosage and the smoother and the faster recovery. Remifentanil and regional blocks. This also allows the combines where the smart approach to pain control. Remifentanil handles the intraoperative pain, whereas the regional block provides the prolonged and postoperative analgesia, reducing the need for the recovery room opioids. This is another entity for which we all are worried, that is opioid-induced hyperalgesia. This is a high, what is the issue here? It is a high dose remifentanil, which causes the paradoxically increased pain after discontinuation of the drug because of its a short duration of action. This is mainly due to the diffuse nociceptive sensation of the mu receptors induced by the exposure to the drug. It resulting in the generalized hypersensitivity to the pain. So what is the solution? As I explained before stopping the remifentanil infusion, we should start the multimodal analgesia. So our multimodal analgesia should start before around 15 to 20 minutes before we think of stopping the remifentanil infusion. So we can combine the remifentanil with other drugs like ketamine, lidocaine, dexmedetomidine, and NSAIDs, NSAIDs, or other regional anesthesia techniques can be used here. So opioid bridging, like administering the small doses of the fentanyl or morphine before remifentanil discontinuation can give an analgesic cliff. And one more thing is we can avoid the very high doses of the remifentanil, which can cause this opioid-induced hyperanalgesia. So there was another study where they use a low dose remifentanil as an adjuvant analgesic in a daycare procedures. And they found that it is not associated with the clinically important opioid-induced hyperalgesia. So What is the take-home message? Remifentanil is effective in a broad spectrum of the patient, right? Like adult patient, elderly patient, from neonate to pediatric patients. Even we can use for the inpatient surgeries, outpatient surgeries, patient with a hepatic impairment, renal impairment, transplant procedures, neurosurgical procedures. We can use in wide range of the patients. It is very efficacious in combination with the IV and volatile hypnotic agents. Here we need to just titrate the dosage of each drug. If we are using volatile hypnotic agents or IV hypnotic agents, we just need to reduce the dosage of the hypnotic drugs. We have to reduce almost close to the 50% of the regular usage. We know it is a fast onset, fast offset, and ease of titration gives a drug. The name is a opioid of the 21st century. It is effective in attenuating the hemodynamic, autonomic, and somatic intraoperative responses. So it doesn't have clinically relevant effect on IOP, ICP, or cerebral blood flow and cerebrovascular CO2 reactivity. So can be safely used in a neurosurgical procedures, awake craniotomies. We can use it along with the other drugs. It should be used with IV infusion only with TCI or TIVA. And the concentration is standard concentration should be used as a 50 microgram per ml. And when the patient, the procedure is over, we should flush the line before shifting patient out of the OT to prevent the after effects of the drugs. So, remifentanil has evolved from the simple anesthetic adjunct to the central pillar of the modern anesthesia and a critical care. Its unique pharmacokinetics makes it a tool for a precision medicine, allowing anesthesiologists to titrate the analgesia in a real time. It's like a designer drug. Ongoing research and innovative techniques are mitigating its drawback, like opioid-induced hyperalgesia, and expanding its utility in diverse situations. The future is titrable. Thank you. These are my some references.
Thank you, Dr. Vaishali. It was an excellent presentation on the remifentanil, which was there. With this, we'll come to the end of our session on updates on the various anesthetic agents webinar on this one. I don't see any questions on the chat box. If there are any questions from the audience, can you please post it?
So we have received a lot of appreciation as I've posted in the chat box, but I haven't received any question yet.
Okay.
Can I make a comment or
yeah, please.
Yeah, thank you so much. All the 4 talks were superbly done. Thank you so much. I would like to add that ketamine is also used in cardiovascular anesthesia in hemodynamically unstable patients to induce or do some procedures if needed. And also, it can be used in patients who have poor LV function because it provides good hemodynamic stability. And as correctly pointed out by Anita, it is useful to reduce the inflammatory response and is valuable in post-operative pain relief in some of these patients. I would like to ask Vinayak whether Remimazolam can be used as a sole induction agent and whether it's a good does it produce good amnesia?
Yes, sir. Remimazolam, a lot of studies have come out for using as an induction agent and for maintenance agent as a part of TIVA.
Right.
And it has all the properties of the conventional benzodiazepines like amnesia in lower doses and higher doses sedation. So overall, it appears to be a good drug. Till we use it clinically, we will not come to know exactly what is this.
Sure. Can dexmedetomidine and Remimazolam be co-administered? Can both be
Sir, they've compared both, sir, but co-administration, not yet, not many, this thing, I couldn't find much literature, sir. They have compared Dexmed with Remimazolam for sedation during procedures. But co-administering, probably somebody can do a study on that probably.
Sure, sure. Thank you. Thank you for that.
Thank you, sir.
Is Remimazolam available in Bangalore?
No, sir, it's not available yet in India, sir.
Okay, I see. Is it FDA approved?
It's FDA approved for general anesthesia in adults and procedural sedation in adults, sir. In pediatrics, it's only approved for clinical studies, sir.
Okay.
There is one question by Dr. Niranjan. Ketamine for spinal anesthesia, is it available presently? Doctor,
It's we have used it I mean long ago as students thesis and all, given as an adjuvant, sir. Not I have not used it as a sole anesthetic agent, though I saw the studies. I have not used it as a sole agent. We were given it as an adjuvant to local anesthetics, mostly bupivacaine. Yeah.
That I agree with you. It's solely used as an adjuvant or a supplemental drug in spinal anesthesia to prolong the duration of analgesia.
Yes, sir.
Is preservative-free ketamine available?
Not yet, sir. It was available earlier as an ampoule form. At that time, it was used intrathecally. Now it is not available. Everything comes in vial only. It's not there. Just
So
last week only I had an inquiry from another hospital about this, but we don't have. I inquired with our pharma also.
If it is not available without preservative, it is not safe to use for neuraxial
The sole anesthetic.
Not for intrathecal use. As of now, as it is available now. Earlier it was available. A decade back also it was available in ampoule. Now they have stopped.
Right. The other thing is when you're giving spinal, you can give IV infusion of ketamine to
maintain, to maintain the hemodynamic stability.
Yes.
That, yeah.
Also, it's supposed to prevent shivering. It's mentioned.
Yes, sir.
Yes. How common is euglycemic? There's one more question. Euglycemic ketoacidosis in patients with SGLT2. Should we
stop all surgeries?
This is for Suresh.
Yes, sir. This when we take SGLT2 receptor inhibitors, especially for cardiorenal protective, if the dose is taken for cardiorenal protective, then the dose is little higher. So they tell if the patient is starving or having some intestinal obstruction or where patients require fluid, fluid changes are more. In this patient, it's seen the euglycemic ketoacidosis are more common, sir.
Right. See, I'm just thinking whether suppose you are not able to stop the drug for 72 hours or 48 hours before the surgery, you have to do the case for some other urgent indication.
Yes.
Can we give sodium bicarbonate infusion to prevent this? I'm just thinking. I have no clue, but I'm just asking.
As we were telling, it's these complications are which is the one which you should be worried, sir. But is it happens for all the patients? It's doubtful, sir. So we go case on case basis. We see if the patient is dehydrated. So they recommend to give IV fluids. Check for sugars. Make sure that sugars are not high or low when these drugs are stopped. And as we go for a major surgeries, we take a pre-op ABG to see the patient is in keto acidosis state or not. So that is what is prescribed, sir.
Yeah,
that is what is advised.
I think monitoring will become important.
Monitoring is very important.
Very
sir.
important.
Check
And another aspect of it is that it does not cause hypoglycemic effects.
No, it doesn't cause much.
That is one good advantage. And
Yes,
it is recommended that patients who are on SGLT2, they should continue to have a good hydration,
Yes,
at
sir.
least drink 2 to 3 liters every day.
Correct,
So
sir.
that is the idea of preventing the ketoacidosis.
They even encourage up to 2 hours clear liquid to be taken in these patients, sir.
Yeah, yes.
Mm.
More, we have to look out for more dehydration features in these patients, and any acidosis is there in these patients before taking for a major surgery.
One more question. Do you routinely combine midazolam glycopyrrolate while using ketamine for preventing postoperative delirium, agitation, and secretions? Anita.
Yeah, so when we use induction doses of ketamine, it is recommended that, and we do use midazolam as well as glycopyrrolate to reduce these side effects of induction doses of ketamine. But yeah, when you're using sub-anesthetic doses of ketamine, that you can just administer midazolam on a as and when basis. It is not seen the post-operative delirium and all, at least as per the studies, that much of the side effects are not seen when you're using sub-anesthetic doses. But when you're using anesthetic doses for induction or otherwise, we have to use midazolam. It is better to use midazolam and glycopyrrolate to prevent the side effects, which are known side effects.
I fully agree with you, Dr. Anita. When it is used in higher doses, like for anesthesia purposes, then it has to be combined with both benzodiazepine and with glycopyrrolate. With nowadays, the current trend, as you rightly explained, is to use sub-anesthetic doses, and in such small doses it is probably not required.
Yes.
Right, right. I see Dr. H.S. Murthy and Dr. Harish, Dr. Rupa Sridhar in the meeting. If anyone wants to add anything or comment, please feel free. So,
Nothing, sir. This is Dr. Murthy. Nothing. There is nothing that I can add. It was an excellent talk by all the speakers, and it was very highly educative. And then this is the first time actually I am participating in this type of webinars by ICA. Definitely, I would be forward to more of this. Definitely, I would join more and then.
oh, sure. Why not? Every Wednesday there is a webinar. We'll put it in the group. You can please join, and whenever needed, we can make your comments as an expert.
Yes.
Sure.
Sorry, sir, I couldn't put on the camera because I was driving all the while.
I
And
know
I
you'll be
started driving
examining.
before the webinar started, and just now I reached home. I'm still in the car.
Yes. I know that you're examining anesthesia
Yes,
uh,
sir.
DNB candidates. Yes.
Yes, sir. Thank you, sir. Thank you.
Thank you for joining. Harish and Rupa, any comments you want to make?
Sir, actually, we have used the DAPA for if you have put arterial line, secured arterial line, you'll get to know the acidosis and all those things.
Correct.
For short procedures, we have done without unknowingly. The initial period we have done unknowingly. We did not have any problem. For long procedures, that hypovolemia, all those things is it is obviously visible. For short procedures, we did not come across any problem. Now also, sometimes if the surgeon insists, we have given with the DAPA on by mistake if they have been taking, and the patient is admitted, we have been giving for shorter procedure. For longer procedures, definitely we avoid.
Thank you for that input. Are there any questions from the panelists? Dr. Rupa, you want to say anything?
Sir, I have used ketamine for epidural.
Oh.
So what I found is it acts only for 6 hours. You have to top up every 6 hours. Perhaps I had stopped using it.
Achha, do you use it as a sole agent?
Only in myasthenics. I've tried in myasthenics ketamine long ago.
Okay, okay.
So it acts only for 6 hours. 6 hours. You have to give top up every 6 hours.
Was it used as a sole agent or it was combined with bupivacaine or ropivacaine?
No, it was used as a sole agent.
Oh, thank you. Thank you for that
Information.
informed.
Okay.
Thank you. Thank you. Kodandaram, any comments or any
Yeah, it was a good educative program, and for the postgraduates, what I wanted to say is that the whatever drugs we studied today, it shows that the old drugs can be used for various new purposes, and
correct?
sometimes whatever was stated to be as contraindications, they turn out to be indications. We don't know how many more drugs will come back for use in future. There are so it is like old wine in new bottle, and in the same manner, some of the old drugs by simply altering the chemical structure, it is possible to produce more potent drugs. Like for example, fentanyl, remifentanil. Even remifentanil can be converted into another compound I read somewhere, which is 150 times more potent, and that is by just putting some butyl ester structure to the remifentanil, existing remifentanil molecule, and it is extremely potent compared to remifentanil. So I want to tell the postgraduates that see whatever the structures, chemical structures are available, by simply modification of the basic structure, it's possible to make drugs which are either more potent, or we can make them even totally not active also.
There is one more question.
It's an
Oh, it's a comment there
exercise
actually.
in chemistry to produce.
One comment by Dr. Muthukumar Rajgopalan that ketamine and dexmedetomidine makes a great combination.
I agree. I totally agree with that.
So, we have used for opioid-free analgesia, sir, combinations of ketamine, dexmedetomidine, and lignocaine. All these in different. I mean, there are various studies which are and under names of whoever doctors have proposed them, and we have given these as thesis topics to our students as well. Various combinations in various doses of. Combinations of ketamine with dexmedetomidine as well as lignocaine in and these patients received totally opioid free analgesia basically for the cases. Only problem which we saw was, I mean, that was the result of those studies that we had done. The post-op, there was some rebound kind of, I mean, we had to use some opioids to treat pain in the post-op. Maybe the drug dosages have to be worked on in these when we make these combinations. Scope for more research.
Sure, sure, sure. I think there are no more questions.
More questions? Yeah.
So I request Dr. Parameswara to make final comments and then I will propose a vote of thanks.
This webinar was basically for drugs which have been coming up and with various newer indications, which not all of us are familiar with it. So that was the idea that we should give, particularly the anti-diabetic drugs like GLP1 antagonist, SGLT2 antagonist. They have additional advantages of cardioprotective as well as renal protective effect, which is very important thing. And GPN1 also has an effect on reducing
Weight
the
loss.
body weight and all that. And of course, Remimazolam is coming up. Most likely that may replace the midazolam which we are now having. And of course, ketamine has been widely used for so many things. And one of the interesting thing which you know is that even in head injury you can use that. even though we say that it increases ICP and all that, but decreases the inflammation. That is what actually causes the decrease in ICP there. So we have so many new drugs. Remifentanil has been already being used, and so I thank all my speakers for having given their excellent lectures on these topics, and it's for you to propose the vote of thanks, Murali. Thank you very much for giving us this opportunity from ICA.
Thank you. It's my pleasure to thank Dr. Parameswara, Dr. Murthy, Dr. Kodandaram for efficiently moderating the session and being with us for the last 2 hours. On behalf of ICA, I would like to thank all the moderators as well as the speakers, Dr. Vinayaka, Dr. Suresh G, Dr. Anita Pramod Nair, and Dr. Vaishali Kumbar for their excellent presentation. And we would like to have you again sometime for another set of lectures. Please join us and be with us in this journey to progress in the sphere of knowledge and with the ultimate aim of benefiting our patients. With that, I would like to thank you, and I would like to thank ClearNet also for supporting this activity. And I think the dinner is getting cold. I think we should go for our dinners now. Thank you so much.
Thank you, sir.
Thank you.
Thank you.
Thank you very much.
Thank you, sir.
Thank you so much, everyone, for joining this session. ClearNet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today. Thank you so much, everyone.
Thank you so much. Good night.
Yes, sir. Good night.
Mhm.